Good evening, everyone, and a very warm welcome to this HSI program. After a small hiatus of about 2 months due to the second wave of COVID, we are back with our academic programs. Since most of our audience and listeners are practicing surgeons, it is time to take our program a step ahead. For the times when just knowing how to perform a procedure is not enough, we have to take a detour from the standard due to either an altered anatomy, an unexpected finding, or a complication. We have three lectures lined up today. The first lecture will be our very familiar face and an expert surgeon, Dr. Ashwin Thangavelu, on the topic of orchidopexy with TAPP. Then we have our ever so dynamic Dr. Aditi Agarwal from Mumbai. She is going to be talking about a series of persistent Mullerian duct syndrome in inguinal hernia repair. I really don't know where she finds all these cases. This will be followed by our own president, Dr. Ramesh Agarwala, who is going to teach us how to circumvent the most horrific of complications, torrential bleeds during hernia repair, and an obstruction from a peritoneal hole in TAPP. So, without any further ado, I will ask Dr. Ramesh Agarwala, sir, to give an introduction of the HSI and start the program. Over to you.
Thank you very much, Pallavi. So as Pallavi said, this is one of our programs. This is Groin Hernia 2, which we are going to talk about. We had a hiatus of 2.5 months because we are quite down because we lost a lot of our colleagues in the second wave, and we are just not up to it mentally to have these programs. Once we have got over it, we thought we will again start. As all of you know that Hernia Society of India is a part of Asia Pacific Hernia Society. It's a very vibrant academic body, and we are into teaching and training. We have different courses, different programs, so that we can take it forward to the people in the different parts of the country and do a bit of hand-holding. Without much ado, I would like to ask Pallavi to take forward these programs. Over to you, Pallavi, to take it forward.
Thank you, sir. And with that, I introduce our first speaker, Dr. Ashwin Thangavelu, who is with us online. And Dr. Ashwin, over to you. Please start your lecture.
Thank you so much, Pallavi, for the kind introduction. So without further ado, we'll just start with the topic. So today I'll be talking on TAPP repairs with orchidopexy. So this gentleman presented with the indirect complete inguinal hernia. On examination, we found that the testis was not palpable on the right side, whereas on the left side it was palpable, but the patient did not give any history about that. And when we did a ultrasound investigation, we found that the testis was found somewhere in the inguinal canal. So the patient was a young gentleman who was not married, and in spite of the counseling, he was not very keen to have a orchidopexy. And even though he was clearly advised and educated that it would not really contribute much for his fertility, but he was willing to take the risk of a malignancy rather than undergo a orchidectomy. And since the location of the testis also was slightly conducive, we thought, okay, we will attempt and we'll plan the orchidopexy and see how it goes and take it forward from that. So like any TAPP repair, I generally like to prefer the dissection to start from the anterior superior iliac spine and gradually go towards the midline. My target would to have around 4 to 5 centimeters superior to the inguinal hernia defect so that the mesh overlap would be adequate and I will not be having too much of a struggle. So TAPP repair comes in very handy in these patients because in this patient, luckily, we were able to localize the testis. Sometimes if we are not really sure where the location of the testis is, and then TAPP kind of an approach would give us a diagnostic laparoscopy view and exact location of the testis. And based on that, we can decide even if we have to do a orchidectomy, it becomes a lot more easier to do it in a TAPP fashion rather than a TEP kind of a fashion. So here you can see gradually we are crossing the midline and entering into the space on the left side below the left rectus abdominis muscle. So here the fat in the midline is incised in a sharp manner, and gradually we are carrying a dissection to the opposite side. So now you can start to see the Coopers of the left side coming into our view, which means we have crossed well over to the opposite side because we want the mesh to overlap the midline by at least a couple of centimeters, which is the standard definition and the standard way we perform the procedure in a good manner. So here now we are dissecting the retropubic space of the radius and creating the medial space very well. So now you can see gradually we have dissected well below the Coopers on the right side now, and we are further dissecting to identify the area of the obturatus. Here a little bit of the fat is present, so we are just dissecting the fat away from the Cooper so that the Coopers can be nicely isolated and it's clearly visible. So this is very important because a lot of the times corona mortis might be a little large in certain patients, and unless we have the entire Coopers exposed, then it becomes a big challenge for us to preserve them. So here you can see this nice avascular cobweb kind of a space is the direction in which we want to perform and carry our dissection. So here you can see again we are working in the nice avascular space. You can see a vessel coming into our view. So that is the obturator vessel, and this is the obturator nerve, the white structure seen lateral to the obturator vessels. So now we open up the lateral space after creating the medial space, and here you can see some fibers which are running from the lateral portion, comes anterior to the cord structures and goes medially. So these are the transversalis sling fibers which have to be divided in order to expose the indirect sac. So once we divide those fibers, you can see automatically the sac starts to come into our visual field, and posterior to that we will have the vas and the testicular vessels as well. So now here you can see the inferior epigastric vessel very clearly, and the hernial defect is lateral to it, so it's a indirect hernia. And gradually we are going to carry with our dissection of skeletonizing the indirect sac and making sure that we safeguard the testicular vessels and the vas in this particular patient, because we have planned for a orchidoplexy rather than a orchidectomy. So here we want to release all these small thin fibrous attachments which are present so that we can increase the motility of the testis as much as possible, so that we will be able to pull the testis back into the scrotum. So here you can see we are trying to encircle the entire sac and the testicular structures, and we are trying to go all around it. So here we just try to make sure that we release all these small fibrous attachments. At the same time, we take great care that we do not injure the small vessels which are running and supplying the testis, because we want to try to retain the functionality of the testis as much as possible without any compromise for the young patient. Even though it doesn't contribute to the fertility part of it, it definitely has a role in the endocrine function of the testis for the patient. So here we just open up the sac in one area and we try to identify which is the area we are going to divide the sac and make sure that the entire testicular vessels and the vas are retained and left untouched, and the maximum amount of tissue which we can dissect off as well. So now this area is the challenging area. It is quite thick and fibrous over here, and we have to do only a sharp dissection. Here we will not be able to do a simple parietalization how we would do it in a normal indirect hernia patient. So here you can see how well these tissues are tethered, and we have to do a nice sharp dissection and keep carrying with our dissection. So now gradually we have developed a plane between the testicular vessels and the peritoneum, and we are going to divide the peritoneum at this level. So the level would still remain the same, similar to the area where we would normally divide the hernial sac, which is somewhere close to the area of the superficial ring or just beyond that. So now again we just make sure that the testicular vessels and the vas area is preserved very well without much of a problem, and we are able to dissect it little further. And now we are dividing the peritoneum so that the entire peritoneum and the hernial sac can be divided so that we can do a nice comprehensive parietalization. So here again, you can see a little bit of the peritoneum is still remnant in this area, and we have made sure that the testicular vessels and vas are well away from our field, and only after that we are incising and carrying on with our parietalization. So this is the defect which we can see, and you can see how tethered the tissues are at this level. So we have to keep on doing a sharp dissection, and once we go beyond that level, then it becomes similar to the parietalization which we would do in a normal indirect inguinal hernia. So here the tissues are not too bad. Here you can easily separate them with a precise dissection, and you can see the cautery also is judiciously used in short bursts and only when we are sure that the vital structures are safeguarded and it is not coming into our field of dissection. So this is the area where the vas will come into our view. So we identify the vas and we make sure that we do not manipulate it by holding it, and we keep our dissection away from the area where the vas is. So here again you can see the testicular vessels very nicely present. The vas is well away from our field of dissection. So here we are dissecting at least a centimeter or a centimeter and a half away from the area where the vas is, and then we tease the perivasal tissue away from our dissection.
What's that far from the vas? Right.
So here you can see we are dissecting it further. So the area where we would stop our dissection is when the vas is turning medially and it's crossing the obliterated umbilical artery, which you can see shown by my pointer. So that is the inferior limit of our dissection, so that the mesh can seat very nicely without any rolling of the lower borders of the mesh. So now we are just trying to see if the entire complex with the testis can reach in the scrotum. So we are making sure that we use a atraumatic grasper, placing it well close to the superficial inguinal ring. We make a small incision in the scrotum, and now we are delivering the testis and making sure that there is no test tension. You can see the testis is nicely coming into our picture. So then we do the orchidopexy, similar to how we've been taught, and that is to the muscle in the scrotal area, so that we can keep it in place and we can avoid any rotation of the testis as well. You can see the testis is actually quite well developed. It's not a poorly developed testis. So we could not say no to the patient when he requested us after knowing the issues. And this is post reconstruction. You can see the vas and the testicular vessels are present very well. There is not too much of a tension or a difficulty in the structure. So we are not too worried about the vascularity in the post-op period. Then we fix the mesh to the Cooper's ligament. You can see since we have isolated the Cooper's very well and dissected all the fat surrounding it, it's easy to fix it. So in order to reduce the cost for the patient and also to maintain the sterility at the best, we generally prefer to switch fix the mesh. And in TAPPs, a minimum of 2-point fixation is done, one in the Cooper's and the other in the rectus abdominis muscle or the anterior abdominal wall. If it's a very large direct hernia or an indirect hernia, we might do a 3rd-point fixation on the lateral side on the abdominal wall above the iliopubic tract. So this would, kind of complete the area where we have done the fixation of the mesh for this particular patient. And we have preferred to use a medium weight macroporous mesh. You can see the porosity very well. And this is a Prolene suture, which we would do similar to a open surgery. We just try to replicate it. And this is the 2nd-point fixation, which we do it in the anterior abdominal wall and the rectus abdominis muscle. So here again, we just use a simple laparoscopic suturing to anchor the mesh. After that, we use a PDS suture to close the peritoneal rent which we have made, as well as the flap which we have created to perform the surgery. So I generally prefer to start from the side away from me and come close to me. So I'm standing on the left of the patient right now. So I just start with the suturing of the peritoneal flap from the lateral aspect or the right side of the patient and come closer towards me, which I find it quite easy to maneuver and perform. So I generally like to use a PDS because it's a monofilament suture. We can take 3 or 4 bites and then we can pull all the sutures together. It has a good functionality and it works very well. It does not really tear the peritoneum. In certain patients, when it's a multifilament and a very thin flap, it can easily get torn in the areas where we have taken the bite. Whereas a lot of the times with the monofilament, that doesn't happen. And this is the completed picture. This is the gap where the sac was divided. So thank you very much for your patient listening.
Nay, Ashwin, it came out very well. As we all know that, we do discover undescended testes, and in 30% of the cases, there is inguinal hernia, whether it's a direct or indirect. And tackling both of them laparoscopically sometimes becomes a challenge. And as you rightly said, if there are cases where you cannot lengthen it, you have to do orchidectomy. But what I want to know is, did you take a biopsy in this case, or do you take biopsies in this case? And you didn't do any biopsy.
Generally, the evidence for the role of biopsy right now is not very conclusive, sir. And usually I discuss it with my urology colleagues and find out what their general practice is. So right now also they say there is not much of evidence to support any biopsies to be done in a routine manner. But we clearly counsel the patient that the functionality from this testis might not contribute towards the fertility. And second thing is, we always do a sperm count before we do any procedure, even if it's an orchidectomy or an orchidopexy. We always take a sperm count, which we keep as a baseline to tell them this is what it is, and then explain all the risks, and that is how we perform with the procedures.
So you counsel them about the chances of malignancy also, right?
Yes, sir. So yes, all these patients have a 5-fold increase of malignancy, which they are informed about.
Yes. So I think you demonstrated it very well. It's technically challenging because when the testis is in the sac, it's technically challenging because you have to open the sac and then dissect the testis and get the cord structure. So it's definitely challenging to do it, but very well done. I think if anybody, any of the other panelists have any questions for Ashwin, or we can go to the next. Pallavi, are you there?
Yes, sir, I'm here.
Yes. So you can, any questions you want to ask?
We will start with Dr. Aditi's presentation.
Yes.
Thank you so much, Dr. Ashwin. It was a really good presentation.
Pallavi, is my screen audible?
We can
see my screen. Am I audible?
Screen. Yeah, and you're clearly audible. Yes.
Okay. Thank you, sir. Thank you, Pallavi, for giving me this opportunity. And after Ashwin's interesting presentation about how to deal with undescended testis, I would continue the same session, another case of undescended testis, which I feel that all of us as surgeons who operate on inguinal hernia and especially undescended testis should know. Especially whenever a patient's present with cryptorchidism or undescended testis on one side with hernia on opposite side. I would be presenting an open hernia case because I had a patient with undescended testis on one side with hernia on the opposite side. My patient was a 40-year-old male who presented to me with hernia on one side and an undescended testis on the opposite side. When I opened, I started operating from the undescended testis side, and to my surprise, the contents of my hernial sac were this. Any idea what this looks like? To me, this appeared to be a uterus, and if you see the picture classically, it looks exactly like a uterus. And the testes here resemble the ovaries. On the same day, I happened to operate another patient who was a 10-year-old male child, again presented with hernia on one side and undescended testis on the other. And again, I found a similar finding of the patient having a uterus with the testis on one side and the testis on the other side. So it resembled like as I was operating a female where she had the uterus and both the ovaries. Because it was a male, it was a testis. I went down to read about it and find what was this condition. And to my surprise, I came across a rare, interesting presentation of hernia, which is persistent Mullerian duct syndrome, which happens to be a rare anomaly. And usually the presentation is with inguinal hernia on one side and undescended testis on the contralateral side. It is basically the persistence the presence of a uterus in a phenotypically male. One patient of mine was a 40-year-old male and another was a 10-month-old child. My 40-year-old male patient, in fact, had 5 kids. And we treated, intraoperatively, we treated this patient with a subtotal hysterectomy along with orchidopexy and inguinal hernia. What was the steps we followed was the open inguinal hernia incision, which we had taken. We extended the incision to become a fan and steel incision. We opened the sac completely. The entire contents were identified and then we attempted to reduce them. Both the testes were identified along with well-formed uterus and the fallopian tubes. Adult male, we could clearly make it out. It looked like how the uterus would present in any normal female. Both the testes had normal epididymis with their vas and blood supply, which was separate from uterus and the cervix. So for these patients, we attempted a subtotal hysterectomy while we preserved the vas on both sides, and both the testes were fixed in their respective scrotum, exactly the way Ashwin showed us in his previous presentation. The adult patient had already got 5 kids, and we have not followed up the 10-month-old kid to know regarding his fertility. We could manage to publish this case in Indian Journal of Surgery, where we did a detailed research and we found out that this condition could present in 3 types. One would be a female type of persistent Mammalian duct syndrome, where the patient presents to us with cryptorchidism, and both the testes would be absent from the scrotum. So when such patients are operated with hernia, we would get the uterus and both the testes in the same sac. The problem with these patients is that the vas difference is very densely adherent to the surface of the uterus. So while attempting a subtotal hysterectomy for these patients, what we have to do is we have to leave at times the remnant of the uterus or do it very flush to the lateral wall of the uterus. So the fertility in these patients at times is a little issue. Next, another presentation would be transverse testicular ectopia. That's how our adult male patient had presented to us. In these patients, our hernia sac not only contains the uterus, but along with that, both the testes are present on one side. So in these patients, we have to extend up our incision, make it fan and steel incision, and then place both the testes down in the scrotum in the subdartos pouch. The third variant, which was hernia uteri inguinale, in this, the inguinal hernia on one side would have a normal descended testis on one side and an undescended testis on the other side, along with uterus fallopian tubes within the hernial sac. This paper is, the detailed paper is already published in Indian Journal of Surgery, which mentions all this in detail. Retrospectively, we did not have any such thought process, but retrospectively, we went back and we reviewed and we could conclude that if any patient presents with an undescended testis on one side and an inguinal hernia on the other side, or with both undescended testis, then in these patients, it would be worthwhile to do chromosomal studies along with an ultrasound or an MRI to assess preoperatively if there is a presence of uterus, fallopian tubes, and testis. It would always be a good idea that if you are suspecting this kind of a picture, to always discuss with your radiologist that you have a thought process of persistent Mammalian syndrome in your mind, so that we can accordingly plan up such cases rather than facing surprises on the operative table. It's not just in male patients I have had surprises. I have even had surprises in female patients. I happened to see a 32-year-old female with an irreducible swelling in left inguinal region. In fact, she had an absent cuff impulse. When I did an ultrasound, we found that she had a cystic swelling in the inguinal region with a high index of suspicion. But still, since we were not very clear, we got an MRI pelvis also done, and the MRI pelvis revealed that she had a swelling with a lobulated contour. And we could not find even the ovary on that side. When our MRI pelvis was done, we went ahead with a plan. We took up this patient laparoscopically, and what we came across was a hydrocele of canal of Napp. So the cystic swelling which we were feeling when we went in intraoperatively, we dissected out the planes as we would have done in a TAP hernia repair, and we came across this hydrocele of canal of Napp. So we realized that hydrocele of canal of Napp is basically a female counterpart of hydrocele of spermatic cord. We managed it laparoscopically, just as it was the way we would pull in while we are doing a complete hernia sac. We pulled in the hydrocele sac, and just as we would have done in an for any appendix surgery, we would have ligated base. Similarly, we ligated up the hydrocele sac, and further we placed in a mesh and fixed it up tackles. Thank you very much. I would be more than happy to take up any questions.
Thank you very much, Aditi. It was very, very interesting. And it was
Thank you.
big learning for us also. I was not aware that these presentations happen. And I'm sure many of us didn't know about this. So your talk has been very, very educative. And you managed to get a couple of such interesting cases and present. Thank you very much. I think over to Pallavi. Pallavi, any questions on your side?
Thank you, sir. Like I said, I am equally surprised. How does she manage to get all these cases? So, so anything that you see specifically during the surgery that takes your mind there, because it's a very rare anomaly, right? So the first time, what was it that made you diagnose this patient?
Actually, these patients I've operated in my rural area. So I had heard from one of my colleagues that once he happened to operate a patient and he found a uterus in a male patient. So when I opened up this patient and I saw something, I was like, this has to be a uterus. It looks something similar. And as a matter of coincidence, I have operated 4 such patients in a span of 6 months. I have done my rural from Chhattisgarh, not very common, but still I have managed to operate 4 such patients during my tenure there.
And one of your patients was socially a female, right?
The second patient which I presented is a female patient whom I recently operated. She came to me with a swelling inguinal hernia. And because I was not getting a cuff impulse and I could palpate a cystic swelling, my first concern was, is it that her ovary is the content of the hernial sac? And that is when I worked her up and I realized that it is hydrocele of canal of Napp.
Okay.
And intraoperatively, obviously, it was confirmed.
Right. So, yeah, very, very interesting indeed. Dr. Ashwin, do you have anything to add to this?
Oh, great series. Congratulations.
Thank you, Ashwin.
So I was just wondering, Aditi, if I was in your position, I don't know what I would have done. I would have only thought that I have forgotten hernia surgery. What am I getting there instead of a testis? I'm getting something weird. And I would have never thought that that could be a part of the uterus otherwise, because, your eyes never see what your mind doesn't know. So anyway, now I'm well prepared. If I get something like this, I'll be able to tackle it. If I can't, I will sort of call you up and ask for help. So we
It's
prepare.
just like doing a subtotal hysterectomy. You
Yeah,
have to just stare up and done. But it's something weird which none of us would expect to see as on a routine.
Good. Thank you very much, Aditi, for sharing
Thank you, sir. Thank you, sir. Yeah.
cases for us. And please keep on coming to HSI programs, contributing. It's always a learning experience. It's a
Yes,
very
sir.
friendly organization. I mean, you just have to take the baton, and you're allowed to take the baton. So you can lead the way, and we're all behind, cheering you and clapping you.
Yes, sir.
Yeah. So over to you, Pallavi.
Thank you, Dr. Aditi. And
Thank you.
next we have some teachings from our own president, Dr. Ramesh Agarwala sir.
Yeah,
He has some really
yes.
horrific videos to show us. So.
No, actually, I was not supposed to come in, but because Vishal is stuck up in the OT, I'm just doing a fill in the gap, and I just had some videos which I just share with you guys.
Yes.
So I'll share the screen. I'm unable to share the screen. Will you
So
allow me a screen sharing?
can you please allow Dr. Agarwal's screen sharing?
This again, groin hernia 2. So, bleeding, this is again the groin hernia. This should never happen. This is inferior epigastric, which you can see. And when you're doing a sharp dissection, sometimes this happens. And you need to know how. Can you see and hear me, Aditi?
No.
Can you hear me, Pallavi?
Yeah, we can hear you, sir.
Yeah. So, you need to know how to, because it's always, don't panic, hold it. Either you can suture or put a clip, but these things do happen. And sometimes you can also use a bipolar. Now, again, while you're doing this, you can see that, again, this bleeding. One has to be very calm in this. You have to get hold of the bleeding. And the previous one, we showed that you could suture. And here, this is not my video, it's a colleague's video. This is holding it. Once you hold it for some time, and then you can cauterize or clip. So here he's putting the clip. So one has to be prepared for such eventualities which can happen. And this, I would just say that this was a recurrent groin hernia. Open right stopa was done before in this patient, and the surgeon tried laparoscopic surgery, which I personally, on reflection, feel that was the wrong choice of procedure, because if you had open groin hernia surgery, there would be lots and lots of additions, and going back into the same plane is asking for disaster. This is what has happened. So you can see the surgeon is dissecting, and this is a great vessel, iliac. So if you have this, the first thing is we have to follow the principles of hemostasis. You take a piece of gauze and press. And when you have these complications, you are not the best person to deal with these complications. So it is always better to call for help. Because the person who is going to help, he is going to be in a better frame of mind. And in such cases, you might have to convert and take the services of a vascular surgeon, which is very, very important. And here again, you see what happens is the TAPP when we don't adhere to the principles. So if you go medial to the medial ligament, then there are always chances of these injuries. So you can see this. So once the surgeon has got medial, it's into the bladder. So one has to be aware, and one has to be here again. The role of suturing is important. So you can close it, but you have to keep the catheter for at least 3 weeks so the bladder heals. And it's a matter of debate whether you would like to put a mesh there, because certain people feel that because the urine in such cases would be sterile, so it's okay to put a mesh. But the others feel that you never know, the urine may be infected. So it's rather you deal with the emergency now and do a late hernia repair later. So there are two schools of thought for both these cases. And this is what, if you go medial to the medial umbilical ligament, such disasters can happen. Now, if you see this patient has an open surgery and he had a hernia. And what happens, this is also again a relative contraindication, as we know, for a laparoscopic repair. But as surgeons, we always want to give the best to our patients, and sometimes we overdo it. So here you see, once the dissection has been done, you can see the cord structures and this. And we are trying to get the medial end. So here would be the symphysis pubis. And we are just using a gauge to bring down the bladder. There were no sharp dissections. So the bladder was so adhered to this area and it thinned out. So just, sort of dissecting with the gauge also caused this bladder injury. So anything can happen. Here you can't blame that you were doing sharp dissections or you flouted any rules, anatomical rules. But in spite of that, it happened. So again, the lesson here would be that you do not, if it's a relative contraindication, it's preferable not to do it, or you may land up in such cases. So this is this. And in this case, if you see, this is post TAPP, TEP. TEP was done by some other surgeon, and the patient landed up after a week with intestinal obstruction. So we never think that the TEP could have been a cause of the obstruction. And as in all cases of intestinal obstruction, we try to put in a scope to see what is the cause, because most of the intestinal obstructions can be dealt laparoscopically, and it prevents the patient having a big incision. So we went in here, but again, we were surprised. So we could see the mesh. So you can see this is the mesh which was put in the TEP repair. And in these 7 days' time, you see how things move fast. The patient came only 7 days after the surgery, and you see the bowel is gone in and stuck to the mesh. So basically, we know that while we are doing TEP surgery, there are rents, which we can appreciate when we see that there is a loss of space. And to deal with that, we often put a Varies needle or a 5mm port in the palmus point and continue. And if you can see the rent, we normally close the rent. But it is always advisable, if you can't see the rent, you can always, after the procedure, do a diagnostic laparoscopy. If you have a 5mm scope, you do it, and then you close the rent. Because you don't know how big or the small the rent is. In this case, this rent was quite big, and you can have these disasters. So here we had to deal with this. So these all are possible. And once you take it off, you try to see that you've not done an iatrogenic gut injury. So these things keep on happening. So this is another video which I had. And so the rent, as I said, loss of space, rent can be seen. You put Varies in the palmus point or close it with endoloop or suturing. But we always do a diagnostic laparoscopy after completion to confirm the closure of the rent, which is very important. And this rent you can close, as I said, either by suturing or otherwise. But suturing is difficult in that closed space. So anyone who has never made a mistake, has never tried anything new, is said by Sir Albert Einstein. Thank you. These are the few videos I had, which I wanted to share as a stopgap batting for Vishal.
Thank you, sir. Very informative videos, and definitely not something that we see every day. It's very important to see this whenever we can and learn from our seniors. One thing, sir, you left the mesh in place for the post-TP obstruction, right? Because
no, we couldn't take out the mesh. So what we did, I didn't show in this video, that we created a flap from the sides and we covered it up.
Okay, so peritoneal
so we covered
flap
the mesh.
was, yeah, right. So it was just flipped over.
Yes, yes. We just kept it over.
Yeah, it did look decently well incorporated.
Yes, yeah, yeah. So because that would have been a big exercise, and again, then there would be a question of recurrence, and then again we would have to close the gap. But because we could find quite a bit of peritoneum there, which we could cover, so we covered it and did it.
Yeah, that's what I was wondering about. That's really a great tip. I was thinking how to tackle the mesh because removing this mesh and it's lying on the vessels, great vessels, so it's a difficult task.
Yeah.
Actually, have you ever used an ICG in these kind of a
But we
situations?
don't have an ICG in our hospital, so I've never used it. So, and I have no experience. We don't have it also. So, and now our hospital is not willing to spend any money post-pandemic. So they are on a very cost-cutting this. So they don't want to replace the instruments which are bad. So we keep on fighting for this basic instruments which have gone bad and otherwise. I guess
Yeah.
maybe if there is no third wave and the hospital makes a bit of money, maybe we'll be able to twist their arms to get us something new. But as of
Yeah.
now, I don't think so.
It's good that the program is being broadcasted live. So
Yeah, I know. And people
yeah.
can see what we are feeling about it and
Yeah.
otherwise. Yeah. So
Uh,
Ashwin, any questions from your side?
Also a great collection of videos. Every time you just surprise us with so much of variety of collection, and
No,
it's like
they're
really
all not
eating
mine. They're
experience.
good friends who contribute, and I just, sort of keep it in folders and use it whenever I ASP. So,
Absolutely, sir. For youngsters, this gives us a great
yeah,
insight that it's not a simple procedure, and we have to be wary of many things and be safe.
yes. Safety is very important. So that's what we have to look into it.
I think whatever questions have come till now, we have already discussed. Sitil, do we have any other questions? Any new questions?
Uh, no, Dr. Pallavi, we don't have any questions.
Okay, yeah, thank you so
Most
much.
of them were covered.
Right. I'm sorry, I think, off for about 5 minutes if I missed it, Dr. Ashwin's video part of it. Dr. Ashwin, did we talk about why did you decide to do an orchidopexy rather than just removing the testes?
Yeah, so in this patient, basically, he was a youngster who was not married and he was very anxious and he was very keen to preserve his testis, even though he was concerned about the risk of malignancy in the future and all that. And we also clearly told him that it might not really contribute to the fertility, but of course, it might have some endocrine function still left in the testis. So this was
Right.
addressed to him, and for the patient's wish, we had to go for a orchidopexy. So
Right.
I don't recall any other patient who we had to do apexy in an adult patient. Most of them were either married or they had kids and they all opted for a orchidectomy. So we have done a few of those, but orchidopexy, I think only for this one patient.
Yeah. Left up to our own decisions. If it was a family member of ours, you would choose.
I would definitely suggest an orchidectomy, even though the data is not too strong. That's the
Yeah, I know.
right way right now to probably go about it. And second thing, orchidopexy in an adult is very challenging. You have to have the right location where the testis is present, and hopefully the vessel should reach the scrotum. A lot of issues like this. Even kids, we have some alternative options. In adults, we literally don't have anything unless you go in for a microvascular reconstruction of the vessels and stuff, which might be even more challenging for a small vessel of these calibers.
Yeah, and sometimes, despite what the imaging says, you might find the testes adhered to one of the intra-abdominal structures or weirdly shaped. We have had to do a partial, colonic resection once with the testes.
Most often, actually, in these patients with undescended testis, they all present with a large indirect complete hernia, and most often it's irreducible. So we actually don't have a diagnosis pre-op because we feel that the contents are sitting over the testis. You can't palpate it and identify it separately. But once you go in with the laparoscope, you reduce them. Only then we actually diagnose the problem, and we realize that they actually have a undescended testis. But a lot of those patients, they will have the testis pretty much somewhere in the superficial inguinal ring area, and it's like a retractile testis which comes to the scrotum, keeps going up and down. So most often they're quite okay. The testis is quite developed, and a lot of them are in the middle age group. So there again, it becomes dicey whether we should really offer them orchidectomy or not, because one school of thought is still like say 50 years they don't have a malignancy. Probably they're never going to develop a malignancy later to that. So it's quite challenging, and we don't have any hard data to say this is the right way to go about it, and the other one is probably not.
Right. Thank you so much. Yes, you were saying something.
No. It's all right. You carry on, Pallavi.
Yeah, I think we are done with the questions. So I'm actually going to hand it over to you for.
No, I think thank you very much. So after a pause, it was always nice to get together and start. And I think we did something different from our previous sessions because, everybody feels that, everybody's had enough of webinars and otherwise, and everybody's saturated. But, what I personally feel is always there's some learning in every webinar and there's something every new. And there are different set of people who come to webinars, not always the same set of people come. And, we have to repeat because life is all about repetition. So you go to sleep, you get up every day, and you can't say, I go to sleep and get up every day, so it's boring. And I eat breakfast or I eat lunch. So you do the same thing. So in hernia, we got to discuss about groin hernias and ventral hernias and the procedures and the mishaps. What else can you discuss? So you can't say that just because you've discussed it once, you can't discuss it again. So, there are some people who feel that, since we've done it last year, we shouldn't do it. But it's always a different audience, and repetition always also helps. So I personally feel it's always good interacting, trying to find. So today, I think Ashwin's case was something very different which we've never discussed. So was Aditi's case. We've never discussed this case before. So it was an insight, and I think it was a time well spent. We've not taken too much of time, 1 hour's time. So I think Pallavi, Ashwin, you guys have done well. You are the rock stars. And I really depend on you guys. I mean, I feel so blessed to have you guys with me. So I think it's been wonderful. So thank you very much and good night. Yes, Pallavi, the last word from you.
Yeah, as always, it's really great interacting with everyone here, and I'm always surprised the kind of work that I see people doing. I never would have thought that someone is doing 4 cases of persistent Mullerian duct syndrome.
Yes,
so,
I know.
Yeah.
I know.
So it's been an enlightening session.
Yeah.
And let's continue this one step ahead of whatever routine we have discussed.
So okay, then.
All right, then. Okay,
I think we can close the session. Thank you very much. Thank you, Docplexus, Chetan, Dr. Sitil, and Aditi, Pallavi, Ashwin, everybody. Thank you very much and good night. And
thank you, everyone. Good night.
Bye-bye, sir. Good night.
Bye-bye. And we hope to meet next week again.
Sure, sir.
Oh, we are meeting this Saturday. Tarun
Right.
is going to program. Yeah. Right. Okay. Bye.
Bye, sir.